Good morning everyone. Today we'll be discussing on management of migraine. So migraine is one of the most common cause of headache. It affects 10 to 12% of the population. Now if you look at the ratio of female to male, it is 2:1, and we all know that migraine will affect the quality of the life. Now looking at the definition, migraine is a familial disease, that is, it is inherited from your family, and it is characterized by recurrent headache, widely variable in intensity, frequency and duration. The attacks are usually associated with nausea, vomiting, and it is mostly seen in one side of the head, like it is a unilateral kind of headache which is most commonly seen. So this is the definition of migraine. Now these are the triggers. Please go through this and understand what are the triggers, what triggers migraine. So one by one, just go through this. Alcohol can trigger migraine, smell can trigger migraine, food, medication, certain drugs can trigger migraine, sound, light, lack of sleep, caffeine can trigger migraine, weather, hereditary predisposition, stress, and if you skip some meal, the patient can have migraine. So migraine has got four stages. There are 4 stages of migraine. The first one is the prodrome, the second one is aura, the third one is the main part, that is a headache, and then you have the fourth, that is the prodrome. Please don't get confused with the prodrome and postdrome. It is not predrome, it is prodrome, aura, headache and the postdrome. So these are the various stages or the phases of migraine. Again, I have put it as a picture here. Now what happens in prodrome? In prodrome, this usually starts 12 to 36 hours before the aura, and the symptoms will include mainly the yawning, excitation, depression and lethargy. So not everyone should, it is not necessary that everyone should have these prodrome symptoms, but it is the first phase of migraine. Then the next phase, that is the aura. I think most of you are aware of this. Aura is a warning, and during this episode patient will have flashing of light, zigzag lines, and the patient will have difficulty in concentrating. That is aura. So migraine, most of the time people will know that they are going to have an attack of migraine, so that is known as aura, and that is the warning signal of migraine. Now comes the main part, that is the headache. The headache, usually I mentioned, it is unilateral, it can also be bilateral, and when the headache happens, the patient will have associated symptoms like nausea, anorexia, vomiting, photophobia and tinnitus. So photophobia is like when the patient goes out in the sun, they will have difficulty in focusing. Tinnitus is some ringing sensation in the ear. Then you have the last stage, that is the prodrome. What happens in in the postdrome? What happens in postdrome? That is after the migraine has subsided, patient will have a fatigue, depression, and they will have severe exhaustion. So these are the phases of migraine. So I also mentioned that not necessary that all the patients should have these 4 symptoms. Maybe the patient have headache and the postdrome, or sometimes the patient will have aura and the migraine as followed by postdrome. So not everyone will have all these 4 symptoms. So there are certain theories. Mainly there are 2 theories of migraine. The first theory is the vascular theory. The second theory is neurogenic theory. Actually there are many theories, but these are the most widely accepted theories. I will teach 2 theories now. The first one is vascular theory. So it's something to do with the vessel, vascular vessel. Now what happens here is there is activation of 5-HT receptor. 5-HT receptor is the receptor which is seen in all parts. It is a receptor for the 5-HT. 5-HT is serotonin. So when there is activation of 5-HT receptor in the vessel, there will be release of nitric oxide. Now what happens when this nitric oxide is released? So we know nitric oxide is a vasodilator. It will dilate the cerebral vessels, and this dilatation of cerebral vessels will result in activation activation of trigeminal nerve terminals in the meninges. So it is a trigeminal nerve terminals in the meninges are activated. This will cause serious sensory nerve discharge. So nerve, when there is something about nerve, we know that it is the pain. So this is the main theory, vascular theory, that is associated with the that is associated with migraine. So now there is pain, okay, the pain associated with migraine. Then what happens is not just that, when the sensory nerve discharge happens, then also these neuropeptides are released. The neuropeptides like CGRP, SP is substance P. So these neuropeptides are released, and these neuropeptides will produce neuroinflammation. So we know neuroinflammation, inflammation is associated with the release of inflammatory mediators like prostaglandins and kinins, and they will produce dilatation of vessels, and the patient will experience pain. So that is the vascular theory associated with migraine. Then you have the next neurovascular theory, that is the activation of arteries. The arteries will release neurotransmitters. That is, when there is activation of arteries, there will be a release of neurotransmitters, and that will cause worsening of the pain. Again, that is the second theory associated with migraine. Now there are two treatments. So let's go to the management pharmacology part. How do you manage migraine? You will manage migraine by two methods. One is we will reduce the symptoms of the migraine during the attack, that is known as abortive drugs. So abortive drugs will abort, or they will terminate an attack of migraine. Then you have the next treatment, that is you have to prevent the attack of migraine. So migraine is classified into mild, moderate, severe. So when the patient is having severe migraine or moderate migraine, you have to make sure the patient does not have attack in the future. So we have to prevent the further attacks, and that is known as prophylaxis. So you have abortive drugs and you have the drugs which are given to prevent the attack. They are known as prophylactic drugs. Now let us see how we are managing each type of migraine. The first one is the mild migraine. So what is mild migraine? That is, we are giving what is mild migraine? Mild is fewer than one attack. The patient will experience less than one attack, or the patient can experience two attacks in a in 2 or 3 months, like that. So it is fewer than one attack in a month, and each episode will last up to it can last up to 8 hours. That is mild migraine. So how do you treat such patients? We will give simple analgesics like paracetamol, NSAIDs, or a combination like two analgesics, two NSAIDs, that is simple NSAIDs we are giving together along with an antiemetic. You can give either an antiemetic or you can just not give. That is why I have put plus or minus antiemetic. So what is the reason behind giving an NSAID? We give NSAID. What are NSAIDs? NSAIDs are non-steroidal anti-inflammatory drugs. So if you go back to the pathophysiology, I told you prostaglandins are released. So prostaglandins will produce dilatation of vessels, and this will produce pain. So we give NSAIDs. NSAIDs will block the prostaglandin. So patient will have a decrease in pain. Now these are the NSAIDs which are mostly effective. Aspirin, paracetamol, ibuprofen, diclofenac and naproxen are effective in terminating an attack. Then one thing I want to mention here is, when a patient is experiencing this migraine, there will be gastric stasis. Gastric stasis. So what happens is, if you are giving injections, the patient will have more effect, and also dispersible or effervescent formulations of analgesics are always better than giving a tablet. Then also please keep it in your mind that excessive use of analgesics can also cause more headache. That should also be taken care. One more thing I want to mention here is, if you're taking the analgesic during the prodromal phase, prodromal is before the headache, you can abort an attack. Now these are the antiemetics you can give. You can give domperidone, metoclopramide, promethazine and chlorpromazine. These antiemetics. Antiemetics are those drugs which are given to prevent or to terminate vomiting. Antiemetic. So antiemetics like these drugs can be given to the patient. Yeah, so that is what I was telling earlier. When a patient has already vomited, it is better to give antiemetic by injections. Again, the gastric stasis will be there, so that can delay the absorption of oral drugs. It is better if you give some drug by injection. Now coming to the next migraine, that is, we said mild migraine, we know how to manage NSAIDs with or without an antiemetic. Now coming to the next one, that is moderate migraine. Moderate migraine means the patient is having more than one attack per month, and each attack will last up to 6 to 24 hours, and most of the time it is associated with nausea and vomiting. So how do you manage this? We give NSAIDs along with so here it is a combination, paracetamol, beta ibuprofen. So we give a combination of NSAID slash, so I have put here slash, ergot alkaloid, and you can put, I have put a slash here again, sumatriptan. Sumatriptan comes to the group of drugs which are known as triptan. So first triptan is sumatriptan with or without an antiemetic. So this is how you will manage the moderate migraine. Okay, so NSAIDs with NSAIDs or ergot alkaloids or sumatriptan with or without antiemetics. So here I want to stress on the fact that ergot alkaloids with sumatriptan or with triptan with ergot alkaloid should not be combined together. So I said in the previous slides that simple analgesics are better for mild headache, mild migraine. Stronger NSAIDs or their combinations are preferred in the moderate migraine. So what are these triptans? Triptans, so here 5-HT1D1B agonist. They are known as triptans. Triptans will inhibit the dilatation of cerebral vessels. They will produce vasoconstriction. So triptans will produce vasoconstriction. Migraine is because of vasodilatation. Triptans will produce vasoconstriction, and that is how they will terminate an attack of migraine. Okay, so that is the mechanism of triptan. So these are the triptans which are available. You have sumatriptan, please sumatriptan, rizatriptan, naratriptan and frovatriptan. These are the triptans. So please go through it again. Sumatriptan, rizatriptan, naratriptan and frovatriptan are the triptans that are available in the market. So what is the mechanism? They will produce vasoconstriction. What are triptans? Triptans are 5-HT1B1D agonist. So these are the pharmacokinetics. We know what are pharmacokinetics: ADME, absorption, distribution, metabolism, excretion. So these are, most of them are metabolized by MAO. So they should not be given with other MAO inhibitors. MAO is monoamino oxidase. So they should not be given with MAO inhibitors. Then they are metabolized by the metabolism by CYP enzymes, and by kidney elimination is naratriptan, and so they should not be given in hepatic and renal insufficiencies. Now some of the very serious side effects of triptans, please understand this, triptans are causing, they can produce serious side effects like coronary artery disease. It can produce coronary artery vasospasm. It will produce transient myocardial infarction. It can produce myocardial ischemia. It can produce transient myocardial ischemia, myocardial infarction, arrhythmias. I have put this in red because they are serious. So please understand that they should not be given in patients who are having cardiovascular diseases, and it should not be given in patients who are having other comorbidities. So this should be in your mind. So that is serious and this should be stressed. So these are the contraindications. Contraindications are the conditions in which you should not be giving the triptan. Pregnant lady, no, it should not be given. Patient with peripheral vascular disease should not be given. Cerebrovascular accidents should not be given. Other coronary artery diseases, I said most of the triptans will produce serious cardiac abnormalities, so you should not be giving them with CADs, and also it should be given in very caution. It should not be given in patients who are having hypertension, that is HTN. HTN is hypertension. Okay, so that is about triptan. Now coming to the next one, that is ergot alkaloids. Again, I want to stress on the fact that ergot alkaloids and the triptan should not be combined together. So ergot alkaloids are, I think most of you will know this, the term ergot, it refers to fungus and it is obtained from Claviceps purpura. There are so many ergot alkaloids. So here you have one ergot, we have ergot alkaloids given for migraine. It is from this Claviceps purpura. What is the mechanism? They are partial agonist of 5-HT1B1D receptor. So triptans were agonists. They were agonist of 5-HT1B1D. This is also an agonist, but it is a partial agonist and it will produce the same mechanism. It will produce constriction of the peripheral and cranial blood vessel. So peripheral blood vessel constriction, so does that ring a bell? It can produce side effects. So what will be the side effects of these? They will produce numbness and tingling of fingers and toes. They are producing vasoconstriction, they produce peripheral vasoconstriction, so they can produce numbness and tingling of the fingers and toes. They can produce nausea, vomiting, so that has to be kept in the mind, and also this can produce hypersensitivity reactions. Obviously it is something, any drug can produce hypersensitivity reaction. They can produce, this ergot alkaloids will produce itching, it will also produce localized edema. About these are the side effects of ergot alkaloids. Now what are the ergot alkaloids? These are the two drugs, ergotamine and dihydroergotamine. These are the ergot alkaloids which are available for the treatment of moderate migraine. Now ergotamine is available as a tablet and dihydroergotamine is available as subcutaneous injection, IV injection, IM injection, and it is also available as nasal spray. Okay. So these are the two drugs which you have to know in migraine, paracetamol, NSAIDs, all that you know from the previous classes. So here you have this migraine main drugs. The new drugs which you are learning here is triptans and ergot alkaloids. Yeah, so something about these triptan is you have to start the treatment as early as possible, and each triptan should be tried for 3 attacks. And if the patient is not responding to all these 3 oral triptans, switch to a nasal or injectable formulation. This is the clinical note. Please start the treatment as soon as possible, begin as early as possible, and they should be tried for 3 attacks. Then ergotamine, the best result when the drug is administered prior to the attack. So even I said NSAIDs, NSAIDs, they also can be given before the migraine attack, so that you can prevent, so that that is better if it is more effective when you give it prior to the attack of migraine. Similarly, ergotamine also, the best result is when the drug is administered prior to the attack. Now coming to the severe migraine, so we already finished mild migraine, moderate migraine, severe migraine, and now coming to the severe migraine, here the attacks are more frequent. It is more attacks, 2 or 3 attacks per month, and each attack is lasting for 12 to 48 hours. The patient will have vertigo, nausea, vomiting, and the patient is very tired. They are incapacitated. So this is severe migraine. So how do you treat severe migraine? You will treat severe migraine. So I have not put here any NSAIDs. Please note that no NSAIDs have been put here. So we have to give either ergot alkaloids or a sumatriptan or a rizatriptan along with a antiemetic. This is how you will manage severe migraine. Not over, you have to provide the patient with a prophylaxis, that is you have to give some drugs to prevent the future attacks. This is the management of severe migraine. So when do you give prophylaxis? This is an important question for your exam. When do you give also when you start practicing, this will be important. When do you give prophylaxis? Please go through all these points. When the patient is having frequent attacks, that is severe attack, and if the headache is lasting more than 48 hours, obviously that is severe headache. More than 48 hours, you have to give prophylaxis. If the severity of the headache is too much, then you have to give the prophylaxis, and the patient has migraine associated with aura. So what is aura? I taught you the phases of migraine, the prodrome, the aura, the headache, and then the postdrome. Yeah, so if the patient has got attack of migraine associated with all these 4 phases, you can give this prophylaxis. Then unacceptable adverse effects occur with the acute migraine treatment. Some side effects are more. Migraine substantially interferes with the patient's daily routine despite acute treatment. That also is one of the reasons for considering the prophylaxis. So these are the points. Please make sure that you learn all of them. So what are the drugs which are given for prophylaxis? For prophylaxis, we give propranolol. What is the reason for giving propranolol? See, the reason why we give propranolol is not still clear. So it seems that propranolol will produce vasoconstriction, and this will decrease the dilatation of coronary artery is the reason for headache, so it will decrease that, and also it will reduce the anxiety of the patient. So we give propranolol. So this is the gold standard of migraine prophylaxis. So first treatment, the first prophylaxis what we give for a patient who is having migraine is the propranolol, and this is the dose 40 mg BD. You can increase the dose to 160 mg BD, and yeah, so that's about the prophylaxis. Then you can also give TCA. What are TCAs? TCAs are tricyclic antidepressants. Tricyclic antidepressants, they will inhibit a transporter known as SERT. It will inhibit something known as SERT, and we have the drug that is amitriptyline. Amitriptyline can be given as a prophylaxis. So I mentioned propranolol can be given as prophylaxis. You can give amitriptyline as prophylaxis. Then there are 2 more drugs which I want to stress here. Anti-epileptics. The anti-epileptics, you can give valproic acid, gabapentin, topiramate can be given, although they are less effective than propranolol and amitriptyline. You can consider these options. Then you have calcium channel blockers, not the usual calcium channel blockers which we give for drugs, which we give for the cardiovascular complications, cardiovascular diseases. So you give flunarizine. Flunarizine is cerebroselective. It will decrease the intracellular calcium overload due to hypoxia. So flunarizine and not the other calcium channel blockers. So that can be given, and it is given at a dose of 10 to 20 milligram OD. The last one is CGRP antagonist, erenumab, can also be given as prophylaxis. So once more, the last treatment is prophylaxis. Prophylaxis is given to prevent the attack, and what do we give? We give propranolol, we give amitriptyline, we give anti-epileptics, and we can give calcium channel blockers. Also, we can consider erenumab. So that is about migraine. Thank you.